Welcome to Live with Hillsdale Hospital. Today is Wednesday, August the 6th, 2025. We're here live in the Hillsdale Hospital studio. And you know what, gentlemen, before we get started, last time I had video in the office here and in the studio, he always wants to hear my jokes because he knows they're so amazing.
Yeah.
So today, what is that a sarcastic yet?
No, it was an absolute.
Okay.
One of the funniest people I know.
Yeah. Okay. Is this how we're going to be? I see how it's going to go. All right. So for the 10,000 viewers that will see this,
At least.
I would like to hear your recovery dad joke.
Well, so I went to Australia and I went to the zoo,
I didn't
and
know
I
that.
was shocked that they didn't have any bears. Do you know why?
Oh, geez.
Why?
They didn't have the correct qualifications.
Oh, wow.
Ladies and gentlemen, and with that,
That's
we're going
music.
to end in prayer
It's a wrap.
today, and it's a wrap because we need it.
That's
You know
it.
what? That's good.
It's fine.
It's a dad joke.
It's a great
My
dad joke.
kids love
I am
that.
going to use it probably yet tonight. I'm going to
Okay.
be around family
Good.
and friends, and they will expect nothing. So if you're listening as family and friends, and I see you tonight, do not spoil the punchline, please.
Yeah.
All right. But it is my pleasure to have in the studio the two Bryans.
Yes.
Okay. Now, we often get them confused because we just say, well, it's the BV. Well, unfortunately,
BVs. Dual
Velker,
BVs.
Velker and Videan.
Yep.
Now, Brian Videan is you're kind of like a staple here, right? You know, you've got Doris, who's been here 56 years. You've got you, who've been here a little bit
Almost
less
55
than that.
now.
Almost
25
56
years. Almost minus like 54. But, you know, you're the senior guy now
Yeah.
on the Pinkley because we've retired Andrew James Bigner,
Yep.
who is not, do you know what's he doing these days?
Absolutely nothing.
I
Doing
bet
nothing.
he's fishing.
Is that right?
Yeah.
So he's
Doing
carrying on his tradition.
Yeah,
So he's
doing
doing
nothing.
absolutely nothing.
As little
And,
as possible.
and probably fly fishing and
Probably.
doing some other things. That's great. Andrew, if you're listening, which I doubt if you are, hopefully you're doing well and enjoying life. But you have turned over, you know, this beautiful unit because it is incredible.
Yep.
You know, now you know the story. I don't know if you know all the story, but kind of heard a little bit during his departure about how this was created.
Yep.
And this, we started in one of the rooms downstairs in the OR one day a week. And Andy was doing it for a few hours, and it was literally in a room that had boxes. And I mean, it was pretty bad.
Yeah.
It was pretty bad. I don't think you started there.
I shadowed down there, so
Did
I
you?
did see it. This was probably about 5 years ago.
So you're probably walking in thinking, what is going on here?
well,
We're in a closet. What is
I
happening?
remember,
Do you remember
the room.
it?
I saw the room.
Okay.
Yep,
Yeah.
Same
Yeah.
thing.
Yeah, it was a little different, but now we're in a
Very
beautiful space because we renovated third floor, which used to be our joint replacement unit. And, you know, we got you the tools you needed and the equipment you needed.
nothing but the
And
best.
we'll talk a little bit about that.
Yeah.
But at the end of the day, a beautiful center
Yep.
in which our patients absolutely love. And we're seeing patients, and this is no joke. We've had patients from Tennessee. We have patients regularly from the Detroit, Ann Arbor area and other places because of our reputation in pain excellence. So it is my pleasure to introduce both Brians here. And
Thank you for
before
having
we
us.
get started, let's talk a little bit about your backgrounds because I think it's important for our listeners to know, you know, all right, who are these guys talking?
Mhm.
Yeah.
They may not know you. They may not have any interaction with you. And could you tell us a little bit about your background? We'll do it respectively.
Yeah.
But let's start with you. Why don't you
Yeah.
give us a little bit of your background? Where you trained? What got you into the business?
Yeah, so lifelong Michigander. Obviously started off as a registered nurse, went into anesthesia, became a nurse anesthetist back in 2008, I believe, and then worked in the OR for a better part of 15 years. Did pain procedures, obviously related to surgeries, blocks, things of that nature, but really found my niche in doing those blocks and found the enjoyment of providing people in significant pain immediate relief.
Yeah.
I would be called into the emergency room when I was working in a rural hospital up in the Upper Peninsula for people with rib fractures. Being able to do injections and help those people at least make it home pain-free was very gratifying.
Mhm. So you responded actually to calls.
Yeah.
Is that right?
absolutely. Yeah, where I was in the Keweenaw Peninsula, it was a single
Pretty desolate.
provider
Yeah.
practice. So I kind of covered everything from OB to ER. To
So you were doing
recovery.
anesthesia
Yeah.
primarily as the only guy.
Yep.
And then you were coming in doing some pain injections.
right.
Wow, that's
That's
incredible.
Yeah. So I think that kind of
Cut your
laid the
teeth,
groundwork.
that's awesome.
Yeah. In terms of like what part of pain as it relates to anesthesia did I really like, and it was the interventional side of things, doing procedures. So then I pursued I did a fellowship at the University of South Florida, which we have a partnership with. And in that process, I got introduced to Andy, and he had me come down, shadow with him a couple times. Really was like just so amazed at how quickly these people would get better, and the gratitude they had for it. And just the sense of pride he had in his work. And I'm like, man, that's what I need to do. So did the fellowship, and then I was fortunate enough to get hired on here. I've been doing it for about 2.5 years now. Focusing on all things interventional, from fluoroscopy, injections, but also using ultrasound, which was in my former life what we used a lot of to treat chronic pain, and have found that to be absolute. It's like that find the job that you like to do and you never work a day in your life, and that's where I'm at right now.
So obviously, this is your passion.
Yes.
And do you miss the OR?
I did initially.
Did you?
But I find myself so fulfilled in a different way. So what was lacking for me in doing anesthesia is I didn't get to see the results of my work, right? Because you put them off to sleep, and then you move on to the next patient. So they were never really, quote unquote, my patients.
That's right. Yeah.
So now they're my patients. I'm accountable to them. I like that responsibility.
Yeah.
I like the relationships. I have great friendships through my patients.
Yeah.
I literally, they come in and it's a hug. How have you been? Haven't seen you in a while. How's things going? So that type of relationship with my patients is tantamount to my success.
And let me tell you something. I often hear, as I'm traveling the countryside, about what you do. And, the folks before Brian arrived, it would always be Brian, and you really picked up where Andy had left off, which was caring for our patients. And you have always cared for our patients, but you kind of become the senior brother, right? Yeah. And so as I go into the community, I hear about the great things that you're doing, but you're changing lives. You're seeing situations where people are coming off of that table, sometimes literally, with no migraine anymore. Some takes a little longer, obviously, for that injection to work. But at the end of the day, it's life-changing. And so I want to thank you for the work that you've done and your commitment to Hillsdale Hospital, because you could be doing this anywhere. You really could. You could start your own practice even. And the commitment that you made to Hillsdale is greatly appreciated.
And I don't think I'd want to do it anywhere else because of the underserved nature of the community.
Yeah.
And many of them just were resigned to the fact that they had to be this way.
Yeah.
And it is a very intimate thing. The thing I tell my patients is the two most intimate things in life are love and pain. And pain is emotional pain, it's physical pain, it's all encompassing.
Yeah.
And you'll have patients come in, they're tearful. Adult men, I had a gentleman in today, adult man, tearful about his pain experience. Yeah. And I was able to actually treat him today and to get him at least feeling better temporarily until we advance his care. But that is the most rewarding thing I will do in life.
Yeah,
absolutely.
Well, before we get to this, Brian, let me ask you a question. You've been around a little while. This is something unique, isn't it, that we do here? I mean, this is to have a pain clinic inside a hospital.
Yes.
Obviously there's reasons why we have to have it inside a hospital, but it's different than what you see in most communities.
Well, and some of it is that a lot of the surgery centers there's a financial side of it, right? That takes precedence over actual patient care.
Yeah.
And I don't ever feel that pressure to produce, to make numbers, to make sure the bottom line is good.
Taking care of our patients.
Just taking care of people, and having it in a hospital provides the benefit of them being able to go get imaging that day. They can get an X-ray that day on their way out. If we have any sort of situation within the hospital where there's a patient comes in in pain, we can address it right away.
And the collaboration with neurosurgery now, I think, is a very good relationship. I want to talk to you about that in just a minute. But before we do that, all right, top that.
Yeah.
I mean, this is your turn. So what brought you into the industry, and tell us a little bit about your history.
Similar path, not quite as not necessarily quite as involved. Mine was same thing, nurse anesthetist. Kind of migrated from Ann Arbor down towards Jackson, OR anesthesia for maybe 12, 13 years.
Okay.
I still do it occasionally. I still like to do it, but more so now on the pain side of things.
So what caused you to want to go to the pain side of things?
So actually, speaking of Andy, so I was somewhat unaware of the pain side of intervention until Andy and I had done some work together, just some OR anesthesia stuff together. And he said, "Hey, you should come check this out." And that's when he was out here.
Yeah.
And speaking of the previous location, the previous rooms and all that, that's where we were. That's where he was seeing patients down there. And the first patient that he saw there was a gentleman that was super, super painful, as Brian described, nearly tearful, very painful, barely able to get in on the exam table, could barely lay still. And when he left, vastly improved.
Yeah. Instantly.
Within a matter of minutes.
Yeah.
And so it really grabs you as like, man, you can turn somebody so fast from a terrible situation.
Oh yeah,
So,
absolutely. Very rewarding.
very
Now,
rewarding.
are I mean, it's not always like that, right? I mean, it's not always jump from the table and feel good. Sometimes, so pain can involve a lengthy process, right? Videan, why don't you give me a little example about what that looks like in terms of the progression?
Yeah. So I'm thinking about a patient again today that, she's 57-year-old woman. She comes in and I'm playing catch up now. She's been dealing with this pain for years. And I always tell my patients, give me a couple months because it's peeling back the onion, because we're going to take care of your primary pain generator, whether it be a hip pain, or I think it was a hip pain in her case. But then as I do my physical assessment, which is something I think that sets us apart from other locations, is we do a very thorough physical examination. I've had patients come from other pain clinics say, wow, you're the first person to lay hands on me to go through this process with me. And then we identify other pain generators. And so what I tell them is that, it's pain whack-a-mole. I'm going to take care of your primary pain generator, but you're going to start noticing these other brush fires in the background that were bothering you
that
we're going to address. Yeah. So our goal is ultimately, can I get you treated in a single treatment? Fantastic. Yeah. But don't worry if you have pain elsewhere, because we're going to follow the pain where it takes us, either through physical assessment, imaging, but also, I think just listening to your patients and I can kind of like extract from them based on when they have their pain or things that trigger their pain, where the generator of their pain is, and then pursue that. So it's a stepwise process. We're going to, bring the patient in on their first evaluation. We do the full H&P. So I'm going to ask all sorts of questions like about your heart and things like that. Yeah. But then from there, we're going to develop an immediate plan to treat your pain. And then we're going to lay out the groundwork where if I'm not successful in that, this is the next step. And then ultimately, if we can't get you comfortable, that's when we have that. I want you to have a discussion with the neurosurgeon to see if he can help you, or an orthopedic surgeon. Because we get orthopedics, we get primary care, we get neurosurgery referrals. And so,
usually they like to give the referral in advance of trying to do any surgical intervention, right?
That's
so
correct.
It's like, let's try to do this with the minimal amount of obviously opening an individual up and the risk associated.
And most insurers require that anyways.
Yeah, they do.
Yep,
let's talk a little bit about that, because let's say it's a single source pain, right? Subject has had a bad back for years, come in, you're doing what you need to do. Patient wants it more frequent. Are you bound by certain requirements, insurance, and help our listeners understand, like, can I get it every day if I want it?
Yeah. So steroid injections, typically what we say is let's say you're having a lumbar or cervical epidural injection, or even SI injections. Most insurance companies will not authorize us to do that more than 3 times in a calendar year. And so the compromise I make with my patients is that I never say I'm going to heal you completely, but what I'm going to do is I'm going to get your pain moderated enough that you could take a couple Tylenol and be fine. The issue is that too much exposure to steroid medications repeatedly can actually be detrimental. It can soften bone. It can make the structures within the joint or within your back less effective and actually worsen your condition. So it's that balance of medication being a good thing, but too much not being a good thing. And so then it's the balance of, okay, what other means can we treat you? Can we use oral pain medications? So then I usually make the referral back to primary care. These are the medications that I recommend based on the patient's symptoms. let's work together to manage their pain. And ultimately, my hope is that they don't have to come see me anymore, but when they need their oral pain medications,
They go back
primary
to the
care
primary
takes
care.
care of it.
Well, that's a big point because, and I'll ask you, we have a
Mhm.
lot of people that ask me, now, Gigi, does your pain clinic give drugs? Do you give opioids? Of course, I quickly tell them no. But there's a reason we don't, correct?
Certainly. So, and as Brian was saying, so the coordination, especially with primary care or whoever sent the referral, many of these patients are well experienced with pain medication options.
Yeah.
They've had several tried on them. Some worked, some didn't. I'm on some. I can't remember what it's called. It's a pill. It's so the coordination is one side of things.
Yeah.
So where we make suggestions back to primary to say, maybe you can think about adding this or tweaking this or changing this dose, I think is helpful to collaborate with them. But also, I mean, obviously over the last 10 years, there's been more of an initiative to say that, the downside of opioids in general, they work fantastic, but the
long term,
there is a huge downside.
Yeah.
So it's the balance of pain control, but also for, managing side effects and expectations.
Okay. So let's talk a little bit about what type of treatment we offer. So Videan, I'm going to start with you if I could.
Yep.
So essentially, you've got a laundry list of things that you can address. Walk us through what that looks like. I mean, everything from migraines to
That's right.
feet. I mean, what
Yep.
what
Head to
don't you
toe.
do, I guess?
Head to toe.
Do
So-
and don't.
Yep. So let's start with the do's. So primarily, most of our practice is axial spine. So neck and back. We work in terms of doing epidurals. One of my favorite things to do and treat is chronic arthritis pain. And the thing I love about it is most of these people have accepted that, I'm
Nature of
old.
it, I'm old.
I'm
Yeah.
But what they don't know, and what I think we need to do a better job of educating the community on, is that arthritis pain is not something you have to deal with. And that's my favorite thing to treat, because the treatment itself is not medication based. It's energy based. It's using radio frequency waves to turn the end of a needle into a little tiny microwave oven, where we create a little tiny burn scar that takes out a nerve that sends a pain signal from a joint in your back. We do that for hips and knees and shoulders as well. And it's the nice thing about it is once you have the treatment done, it can last anywhere from a year to 2 years. So then you're off the hook. You don't. And as somebody who's had both my neck and my lumbar spine done by Andrew in the past, I see the results. So I was gifted.
Yeah.
My curse is my gift. I have a great understanding of patients' pain because I have it. I have degenerative disc disease in my low back. I also have it in my neck. I've had a neck injury, and I can see the results. And so I can talk to a patient and be like, does it feel like this? Because I'm coming from that place. I know that.
Right.
So then we do joint injections. That's why we'll get our referrals from orthopedics. And then we'll do kind of some nuanced things. We treat complex regional pain. I have a patient I'll be seeing this week for treatment and complex regional pain related to a crush injury. And then odd things like today we did a ganglion impar block, which is for somebody who as a child broke her coccyx and has this terrible pain in her bottom. And again, using live x-ray, we can place needles and treat that. And she was actually one of those people who got better immediately after the procedure was over.
That's incredible.
So it's a very fun job, especially if you like to work with your hands.
Yeah.
But and then in terms of headaches, that's another one. Is headaches can come from nerves, but they can also come from joints in your neck that can cause them. And so then it becomes incumbent upon us to do the good physical assessment to determine what that generator is.
Yeah, absolutely. So individuals that come in, what's your specialty? What do you like? I mean, is there anything, you have a sweet spot?
So, I mean, primarily, I think the most mileage that you can get on a patient is low back pain. So there's so many patients that we see. The biggest thing we see them for is low back pain, bottom of the spine, just constant movement pain. And I think part of me, gravitating towards that right now, I mean, the headaches are fantastic to get rid of. But you can make so much mileage fast with somebody that has chronic low back pain. Yeah. They've likely had it treated somewhere else. Maybe they were at a different clinic or tried this med or that med, and you can really bring someone along quickly with just plain vanilla low back pain, you can move them along to a place of,
Yeah.
like Brian said, take 2 Tylenol. The pain's not gone. It's very hard to make
Right.
some, a 0 out of 10 pain, but the pain is definitely more manageable than it was previously.
So would you say you have more patients presenting on a consistent basis? Is this, there's a concept of one and done. Is it kind of hard to say it's one and done in pain clinic? Like it's not just you go get your surgery and you're done, really. I mean, you may go to PTOT, but you're pretty much done. But for you, is it more long-term?
I would say typically when a pain patient comes in, more often than not, it's going to be 2 to 3 visits before you really kind of get that person back to where they want to be. And most patients are okay with that, because as long as they're moving forward towards that goal.
Yeah.
Yes, it is nice, particularly with younger people. They tend to respond better to single injections because they don't have the degenerative disc disease on top of the arthritis yet.
Mm-hmm.
So they haven't got the arthritis component. The origin of all this pain in our necks and our backs, primarily, I know we keep talking about that, is you have a flattening out of the discs, which are the shock absorbers of our spine. They're like little marshmallows. And as they squeeze out, because they're getting pushed down, they can push on nerves, causing that leg pain or arm pain. So those people tend to respond really well with a single epidural injection. Sometimes we'll do a second one and then they're good to go. But then that squishing down of those discs leads to arthritis, meaning that it changes now the orientation of the bones, where they relate to one another and they start to grind or pop over each other. And that's where we transition their care. Again, ultimately, if we can't get them where they want to be through our interventional means, then it's a conversation with them. Okay. And I always say a pain is the great motivator, meaning that everybody has that breaking point where they're willing to first come to a pain clinic. But secondly,
take the steps.
Pain clinic couldn't get where I want to go. And then I have a great neurosurgeon in town, Dr. Logan Nathan. I can say, just have a conversation with him. And he's really good about sitting down. He has the same practice that we do.
He does.
He's very interpersonal.
He is.
It isn't like when you come in to see me or him, it's not sitting at a computer and him going like this.
No.
It's, I'm going to have a conversation with you as a person. And I do that because I'm also a patient, right? So I go see my primary care. And I remember when I was in Ann Arbor, primary care come in and they do this and they don't even look at me.
No.
You're never going to see me do that. I know Brian's probably similar. And I know Dr. Logan Nathan is. It's a personal relationship. I mean, it is, you are giving somebody say over your body and your health, and you better be able to look them in the eye and say, hey, listen, I'm going to take care of you. I'm going to do my best to take care of you. I don't have all of your answers, but I have many that make your pain at least more tolerable.
Absolutely. So let's talk about the communication back to primary care, because I think that's critically important. You have a patient that presents. They're usually here, generally speaking, because they've been referred.
Yes.
Generally speaking. Some may just wake up and say, I need pain clinic intervention. But generally speaking, they're referred. How does the communication work? We'll start with you back to PCP. So my primary care physician refers me. You do the injections. Are you communicating back with primary care?
They typically communicate with us regarding what the patient, originally presents with, what they're sending them our way for. And that will lead the conversation of what we need to kick back to them. So depending on what they're there for, if they're there for a knee injection, if they're there for, shoulders, anything up and down the spine, the kickback to them would be adjusted according to what the patient would specifically need. So if they're there for a knee injection, not necessarily a lot of communication needed, because they know, okay, they're going to get their quarterly injection at the pain clinic. If they're there for something that's more spine related, I mean, some of these patients have a very significant advanced history to where there's coordination needed back to.
Oh, sure.
And they have multiple different people they see, not just primary care. So the coordination is important on the backside and that generally comes with a specific request of what they're coming to us for.
So Videan, let me ask you this. So when you're meeting with the patient, is there a portion of this that's exploratory? Or is it, they come in with an area of pain, but you have to diagnose and you have to treat, right? Because a diagnosis from PCP could be, I think you got X. And you're like,
that's right.
Yikes, that is not even why.
And so what we'll get a referral for, let's say, I think it's hip.
Yeah.
And then I do a physical assessment and find out it's the sacroiliac joint, which is the posterior pelvis.
Yeah.
And a lot of times what I'll do, just to be collegial, is contact back to whoever it was that referred and said, listen, I couldn't listen. I've had this happen with Dr. Logan Nathan as well. I'm not seeing this in physical assessment.
Yeah.
I think what we have the advantage of is that a primary care provider, they have the whole patient.
Mm-hmm.
They have every facet of that patient. And I get the advantage of a very specific thing. Everything is pain related.
Mm-hmm.
And then what I call it is triangulation. If I have imaging along with what the patient tells me and then my physical assessment all in lockstep, it's very hard to be wrong.
Right.
And so if I can get triangulated on a patient's pain, it makes me more successful in the treatment.
Mm-hmm.
And then the trust that I've garnered through my practice, but in the referrals and the patients responding back with their primary care, that took care of it. Yeah. I don't necessarily, because they were referred for that, I'm not just honing in on that.
Sure.
I am going to do my full physical assessment. I'm going to talk to them.
Yeah.
They're going to give me answers that I understand as a pain provider that maybe a primary care provider wouldn't have clued into.
Yeah.
And then from there go and then communicate back with primary care or neurosurgery or orthopedics. Hey, here's what I saw.
In collaboration.
Absolutely. I don't ever
important.
try to usurp them, but I also want to make sure the outcome for the patient
diagnosis.
is what they want.
Yeah.
Correct. Yep.
All right. So we talked about what we do. Is there things that we just absolutely don't do? Are there things that we just try to say, you know what, that needs to go somewhere else?
Things that we don't do.
And Videan, jump in if you think there are.
I don't know.
I mean, I know we do a lot.
So there's a very specific treatment for like pancreatic cancer, or there's a celiac plexus block, which is something I personally believe needs to be at a University of Michigan hospital, something like that, because complications in that can be high, and at least at that facility they can handle it. I'm going to flip it and say there are things that we do that some pain clinics I know in the area that have closed recently didn't do. It's a lot of neck procedures.
Yeah.
I know that the clinic in Marshall at the time wasn't doing them because I've picked up patients from them. And some of what we do is better than other pain clinics because we've invested in better equipment. And what I mean by that is the ablation equipment that we use for chronic neck arthritis is the best that is on the market. It is probably more expensive, and that's why freestanding facilities would avoid it. But the results of that treatment are so good and so worthwhile that, and it's so much safer for the patient, most importantly, that we can kind of hang our hat on. That is something that the Hillsdale Pain Clinic does that a lot of places don't. Also joints. The ablation procedures for joints are something that not a lot of facilities do.
We'll talk about what that is, because that's an important procedure.
So one of the things that we do I'm hoping with insurance, they're going to open it up to more things. Yeah. There was a time we were able to do it, then they've kind of locked things down. But with Medicare now opening up these procedures, insurance usually follows. But I'll use a knee replacement as an example. As somebody who has chronic knee or hip pain after a replacement surgery that is refractory to the surgery itself, medications, and then conservative treatments, we can actually go in and do an ablation where we turn off the nerves that send pain impulses from the hip or knee or shoulder, as it were. And that is really, really effective for people. I have one woman, she was from California, and she's been all over the country for various reasons related to work, and has had bilateral knee replacements and chronic pain with both of them. And I have done, over the last 2.5 years, she's had 2 sets of ablation procedures spaced out by about a year and a half. She went from walking with a cane or even a rolling walker to now she's walking without.
That's incredible.
And it's so rewarding. It's like one of those, she's one of my favorite patients. We get a big hug when she comes in and everything. And I have a personal relationship with her. And I feel like there's an area for that to grow. I'm hoping insurance will get on board with it, but for sure. So Medicare pays for that. A lot of those procedures that we're doing with joints, we just
hopefully the commercial will follow it.
Yeah, there's a couple there's a couple that are starting, but we battle with the blues in that. But
and you're doing that right in the office.
Yeah,
coming right up to the floor. You're engaged in that procedure.
Yeah.
So I had a question posed to me last night, so I think this is timely. Does your pain clinic treat terminal pain? Now you're saying terminal pain. All right. This particular situation was asking me about cancer patient who is in a lot of pain.
Yep.
I don't even know what stage they're in or anything of that nature, but I think it's a question worth asking
Yes.
to see if there's any opportunities there. So, and I couldn't answer that because honestly, I don't know. You're going to educate me on this whole.
So yes, we've seen that. I've had a couple patients in the last several months actually who we found cancers on through our scans.
Okay.
But also patients that were admitted to the hospital for chronic pain. And what we do is pain is also protected. So we have to be careful about what we do.
Because it's telling you something's not right.
And so if I could turn off all your pain signals.
Yeah.
But we have to be careful, like for, let's say somebody has metastatic bone cancer and they've got a really weak vertebral body in their back because it's turned to Swiss cheese. So I could definitely turn that pain off for a period of time, but I also could put them at risk for hurting themselves through movement. And there's another procedure called kyphoplasty, which is a better procedure for them. Dr. Loganathan does that. So it's a case-by-case basis. We're going to do a full physical assessment on you. But yes, have we done that? Absolutely.
Right.
It's just going to be, what does the imaging say? Where's the primary source of, say, it's a cancer? And then is this just a result of metastatic disease that's causing chronic pain?
Right.
Yeah, we'll look at it and treat it. We don't rule anything out.
All right. So it's an option. The second follow-up question to that was, if they are accepting someone for that, do they have to go off of their opioids because they are also on, obviously some pain control, but that's not a requirement, right?
Opioids are really great for cancer pain and post-surgical pain. Those are the only two things study proven to show their effectiveness. So absolutely, I would not have them come off of that.
Yeah.
I mean, yes, could they for that short period of time? Sure, but their pain's going to return.
Right.
And then you have the side effects of withdrawal and things like that. I would say they're better off to stay on those medications. Sure. Let us help them, and they might be able to reduce their dosages, but I wouldn't say ever that they would come off of those medications.
Okay, very good. So those were timely questions because those were literally just posed to me yesterday. So it's great to hear that. Real quick, we'll wrap up here. If a patient wants to come in and they don't necessarily even have a PCP, they don't have a primary care physician, we still have that exists in our community.
Sure.
What can they still access the center?
So they can still access. I would say most patients come to us via referral.
Okay. But I can call up, right, and say I want to make an appointment.
Yeah. And then what we'll do though is what's really helpful is, primary care sees them, get some imaging available. So we have that have that.
True.
And what that does is that speeds up the process of treatment because sometimes I have to bring a patient in for the first eval. I have no imaging.
So you have no imaging. You got to send them back. So it's just a consult.
A primary care referral, orthopedic referral, neurosurgical referral, chiropractor referral. Any one of those things helps get the ball rolling. And many times they'll have imaging associated with it. And it does speed up the process on our end for treatment.
And in many of these cases, you're returning the patient back. So let's talk about chiropractic care, because that's one where you may do your injection, but they're still going to go for their treatments, correct?
Mm-hmm.
Yep.
So that doesn't have to stop. This
hand
can help.
in glove works together. And physical therapy the same way. There are certain things that physical therapy helps with. There's certain things I don't think it really does a good job with arthritic pain. That's my job. But myofascial pain, disc pain, physical therapy is great for that. So we will make a plan that doesn't exclude any of the treatments that they're getting.
So do you do referrals to PTOT or does
you want for sure?
So you do it.
I've done, and I've done referrals to orthopedics, again to neurosurgery.
So if a patient comes in, you will say, we're going to do the referral beyond this or in conjunction with.
Yep.
And then how is that communicated back to primary care? So if you say, you know what, I want you to go see Dr. Carr. Yeah. And is that communicated or is it just expected?
So in many cases, I have a referral form. I just send it to him and then I fax my information.
Very good.
One of the nice things is having a personal relationship with Dr. Loganathan is I can literally text him or his wife and have an answer for a patient while they're sitting with me and get them an appointment.
It's incredible.
And I can triage. I can say, listen, this patient absolutely needs to be seen by you immediately. And they always accommodate.
It's incredible.
There's not.
I was texting this weekend
find that.
Over a patient. I mean, the guy is responsive,
Yeah.
and it's just great to have that,
100%.
that care. And of course, you're always available.
Yeah.
And I know that I've reached out to you before, even in the past, and I think that's what makes our program different.
Yeah.
Is it's not we shut down at 5 o'clock. We're done. It's that we're always available.
And Brian and I have known Dr. Logan Nathan for
Long time.
15 years.
Yep, long
Is
time.
that right?
Yeah. So it's that background of working
Relationship
with him,
that you have with them.
worked with him in the OR doing
Yeah.
anesthesia, and now on the pain
Yeah.
side of things.
Yeah.
So it's an absolute collaboration in the fullest extent.
Yeah. Last question is, there was a lot of talk and buzz around the ganglion blocks for COVID relief.
Yep.
Are we seeing much of that anymore?
It seems to be tapering off
Is it-
quite a bit.
Insurance doesn't cover it still.
Correct.
Correct.
Yeah. And I think that, will we still do it? Sure. But have we seen the numbers that really would say that that's a big part of our practice?
No,
I would say no.
And it's expensive.
It is. Yeah. And people, obviously it's
It's like a 50-50, right?
it
Honestly.
is. And it's not, I'm not going to, here's $600 for a guarantee. That's
right.
the challenge
Right.
with it.
Right.
And so, and that doesn't make me feel good, right? Because I want to be able to help you.
Yeah.
And then to know that there's also a financial impact if I don't help you, that's a
Yeah.
tough thing to kind of swallow for me. So it's really got to be the right situation. They've got to have a pretty good history of, and when they come into that point, they have lost sense of smell, sense of
Yeah,
taste.
they're
all the
desperate.
pleasure in their
Yes.
life
It's
is
desperate.
gone.
Desperation
They
time.
absolutely
Yeah.
are willing to try it.
Excellent. So, okay, let me ask you this final question. I do promise. Is tell me of your most like amazing success story by just virtue of the example. Like, Andy gave me an example of he had someone that was suffering terribly from migraines. He injected instant relief. She got up, she hugged him,
Yeah.
and she was crying. And she only came back a few times after that, he said, but he'd see her at the store, she'd hug him. Life is different. Do you have a success story that you're proud of?
One I always talk about is a gentleman who came. He'd been to Mayo Clinic. He had been to Bethesda. He'd been all over for these chronic headaches and seeing neurology. He's on his second neurologist. They haven't been able to get his headaches resolved. And his headaches were so severe, and every single day that he had the number of days that he'd had headaches, it was 1,672 straight days of headaches.
Wow.
And I was like, has anybody looked at your neck? Oh, they've never been able to get it, even with the neck. But nobody had looked at arthritis being causative. And there's an area within your neck where if you develop arthritis, it can lead to headaches specifically.
Mhm.
So we did a diagnostic block on him first, where I just put in local anesthetic in certain areas. And this is a guy who he comes in sullen, very pessimistic,
Yeah, 1,700 days of headaches.
pretty
It's a
crabby
long time.
dude,
It's a
to
long
be
time.
honest with you.
Life is bad.
And
it is.
he
When it-
called the next day and he says, that's the first 24-hour period I've never had a headache. Now, the
Wow.
success is that
Wow.
I ended up advancing to the ablation, got him better, and I haven't had to see him back, and it's over a year.
That is
so
incredible.
that
That's
one
a
always
huge
stands
success
out
story.
to me.
Absolutely.
Yeah. Just
Just
in his
impacting one
demeanor
life. Yeah.
and how sullen he was and how
It's life-changing.
absolutely depressed he was, and then to see his whole image was just like a happy
Disposition
person
all
again.
changes.
Mhm.
That's incredible.
Yep.
What a great story. How about you?
So this was just a couple months ago. I was working with a guy on his shoulder and Brian was talking about this earlier, where we treat those nerves that go to the capsule of the shoulder. So if someone's already had a shoulder replacement, they have limited options at that point. Typically, somebody would say, "Well, just get a shoulder replacement." Well, I already did that. What else? What else you got?
Yeah.
And long standing. I mean, his replacement was 10, 15 years ago. Been dealing with it a long time. Couldn't lift his shoulder past, probably that high, and had just come to live with it pretty much. And we did some diagnostic blocks on him, promising, but you always kind of cross your fingers that you're going to get that same result. And he had a fantastic result. We saw him 4 weeks later, and he could get it, significantly higher, was feeling, pain was 80% gone.
Mhm.
And he was saying how he could put his shirt on normally.
Isn't that
now.
amazing? Just the little things we take for
stuff where,
granted.
like,
Yeah, that's
just
incredible.
putting your shirt on.
Yeah, that's incredible. So the moral of the story is you don't have to suffer with pain. There are options available right here in your backyard at Hillsdale Hospital. Beautiful renovated floor, third floor, opportunity for you to come in, either self-referral. You want to call the office to make sure that you get your x-rays and other things done, or by your primary care. I would encourage you, talk to your primary care. You most likely already are talking to them about your chronic pain, but let them know that you heard this episode and that you're most interested in a referral to the pain clinic, they'll give you a referral. These guys will get you in within a matter of just a couple weeks. We like to get those folks in, because if you suffered for a very long time of pain, every day is a challenge for many people to even get up out of bed. So there are options, and this team is phenomenal. The training that has been done by this team and the work that they do, I hear in the community all the time that it is truly life-changing. So I will thank both of you gentlemen.
Thank
You are doing, I say, God's work. It's mission-minded work. You're not just producing gadgets, you are impacting lives every day in our community. And the stories are plentiful of the people and lives you touch, including my own family, that you guys have touched and impacted in a positive way. So thank you for what you've done.
And thank you for supporting us.
Absolutely.
We have all new equipment.
Yeah. And it's necessary, right?
That is absolutely such a great thing to be able to have the best imaging equipment, the best ultrasound, the best ablation equipment. It's all state of the art.
It's great for patient care as well.
Absolutely.
Well, thank you, gentlemen. Are there any questions, Ms. Brown? None. No questions. All right. Well, for those of you who may be listening to this later, and we do have thousands of people that do that later, please feel free to drop us a question in the inbox, and we'll be more than glad to answer that question or get one of the questions over to one of the Brians. If you have a specific about pain, we don't try to answer it, trust us, but we get it to the experts, and then we'll respond to you. For information about the pain clinic, we're going to put that in the show notes so you can see how to contact the pain clinic. Again, the critical nature of this is to talk with your primary care, so that way they can develop that plan together. It's always good that your primary care knows what other services that you're getting for their continuum of care for you. And we would encourage you to visit our floor. If you're thinking, you know what, I don't even know if I feel comfortable going into a facility. It doesn't feel like a sterile facility. It is a very nice environment. They're friendly. They're great people to work with. Your staff, do you want to give a shout out to them?
Fantastic. Absolutely.
They're great.
We've added staff.
Yeah.
And that's related to us being busy, but
absolutely,
they are all like, I can count on them.
Yeah.
They're dependable. They are wonderful with patients. Again, we have our own little area that
we do.
is very nuanced and specific, but at the same time, we're still a family.
Yeah, you're clicking on all the cylinders. It's really great. And so a great opportunity for you. Contact the pain clinic, get in, be seen, don't suffer pain anymore. There are options that are available. We want to thank you, our community, our listeners, our patients who trust us with your care. That means a lot to us. The ability to sustain this hospital into the future really depends on your continued utilization of services like the pain clinic. You can travel. You can say Mayo's got the best or Hospital X has the best. I'm going to submit to you, we've got the best. There are resources like this that people are coming to us from other states to receive care at our pain clinic. That is a testament to the work that these gentlemen do each and every day. And for you, you do not have to leave the comfort of your community right here in communication back to your provider. So thank you for using us. If you're looking for other services that we offer, you've heard these gentlemen talk about Dr. Loganathan. He's a neurosurgeon. We have vascular surgery here. We have urology. We have general surgery. We have a full litany of services that we offer in a full continuum of care. Most rural hospitals don't offer that. We do. We're rare. Go to hillsdalehospital.com to learn more about those services. If you're looking to join an award-winning place to work, we are that place. Hillsdale Hospitals received numerous awards for recognition for being the best and top employer. We may be announcing some news in the future as I'm getting probably the dirty look here. We are going to be announcing something very exciting in the very near future about some of those awards, but we have often talked about U.S. News and World Report, top nursing home in America, 11th year in a row, I think we are now. We are a Detroit News top employer. We're a Chartis Hospital top hospital. The list goes on. If you're looking to join an award-winning team like Hillsdale, we have openings. I think we have close to 40 right now that are available, and it doesn't require you to have masters and bachelors for all these positions. In fact, many of them are entry-level jobs that you can sign on. We sponsor. I've sent individuals to become a CRNA. I've sent individuals to become PAs, NPs, and the list goes on. It's an opportunity for you to advance your career and change your life. And so if you're interested, go to hillsdalehospital.com / you can go to careers. The careers tab will list all of the job openings that we do have available. If you're looking to make a donation, we'll take those too. You can see our donate tab on that same website because we do need to support services like the pain clinic. There are many people that cannot afford their health coverage, and so they cancel it and they come into our ER and they need services. And we as a hospital provide millions of dollars back to our community for uncompensated care. If you're looking to make a donation, please go to our website and you can see the donate tab. We'd love to hear from you, even if you want to drop us a line and say, I was there, Nurse X did a great job. I was there, the pain clinic did a great job. We love to tell patient stories. That's a place for you to do it as well. And last, I am excited to share a new, we're going to launch a new initiative. And we've often talked about, Hillsdale Hospital Strong. We are launching a new initiative, Rural Health Strong. And to us, it's very important to sustain rural healthcare in this country for many years to come. Now we're challenged. The big, beautiful bill is doing us zero favors, creating some very, very difficult times for rural hospitals across this country. In fact, 800 plus hospitals are forecasted to close by 2032 as a result of this legislation. We got to do something about that. You can be an advocate for us. You can tell your congressional leaders, this is bad. This is very bad for our economy. It's very bad for rural healthcare. It's very bad for our patients that they cannot get care that's going to be hundreds of miles away. So we would encourage you as we launch this new initiative, and you're going to see it up on the screen, Rural Health Strong. We are Rural Health Strong. So until we see you next time, stay safe, stay healthy, and stay Rural Health Strong. Thanks for joining us today.